afternoon, folks. This is Teresa Hatton with the Office of Health Transformation. Just as a reminder, we are going to get started here in a moment, but if you have any questions during our presentation, please utilize the chat feature on the webinar toolbar. And then, in addition, we will also send this document out to everyone on the line today, and we will also record this webinar so that we can post it on our site later today or first thing tomorrow. And I'll pass it off to Greg Moody.
Okay, thank you, Teresa. Hello, everyone. This is Greg Moody. I'm the Director of the Governor's Office of Health Transformation. Thank you for joining us for this update on the episode-based payment model for the state of Ohio. We also have some other updates for you in this presentation and want to share primarily some news that because the project's been going so well, we are actually going to accelerate the work and design an additional set of episodes this year. The starting point, I think, is to say thank you to all of the folks who have participated in this effort. The invitation for this webinar went to everyone who worked with us, either designing the original episode framework or subsequently participated in clinical advisory groups to design specific episodes. Thank you to everyone. In addition, the payers who continued to be at the table with us, adopting the same definitions that Medicaid's using, so hopefully we can start aligning expectations and financial rewards across payers in a way that make it meaningful at the practice level. For the agenda today, we're going to provide an update on some progress to date. We're going to review some details about the current set of episodes, including thresholds for the performance period, and look ahead to information about future waves of episodes. Before we move into the episode detail, there is some new information on the primary care side that I know some of you on the call are familiar with and are interested in. We are ready to launch the state comprehensive primary care model, and we believe it complements a new opportunity from the federal government to also bring Medicare to the table through what they're calling the Comprehensive Primary Care Plus, or CPC Plus, initiative. Just a reminder about how Ohio's patient-centered medical home model works. The idea is that any practice, even small practices, 500 or more Medicaid members, that perform certain activities that are known to keep people well and hold down the total cost of care, for any practice that engages in these activities, the state wants to flow an additional per member per month amount to support those activities as long as certain efficiency measures are met and clinical requirements are met. And then for practices that are holding down the total cost of care, sharing back some of those savings with the practices. So this model is something we've been working on for a while. We were getting ready to launch it this month when then the federal government announced the CPC Plus initiative. Our program was to start January 1, 2018. But now with CPC Plus, we see an opportunity actually to go a bit earlier than that. The primary care model builds on work that has been underway in Southwest Ohio, a comprehensive primary care initiative endorsed by the federal government that the federal government has started calling CPC Classic. That was a 4-year demonstration that is set to end at the end of 2017. We were preparing ourselves with Ohio's statewide model to turn it on in time to let those CPC sites come into the statewide model. And then as we were doing that work, CPC Plus came along and created an opportunity to bring Medicare to the table also beginning in 2017. There is an application process underway right now for CPC Plus. Payer applications are due June 8th. We believe all of the state innovation model payers are planning to apply. We have proposed as a group that the state of Ohio be a single region for the purposes of CPC Plus, and we hope to receive that designation sometime by late July. If Ohio is designated a region, then practices in Ohio will be eligible to apply to become CPC Plus sites. Nationwide, CMS is selecting around 5,000 practices. We are preparing a detailed process to recruit practices into this application process. And as we have additional information about the federal application process, we'll be sharing that directly with practices through their associations. Okay, so thank you for the slight diversion on primary care, but those developments I think are significant enough that we at least wanted to make sure folks were aware. Now back over to the episode model. We are right on track from the original plan where we've been able to create about 6 or 7 episodes a year. We have 13 currently designed, and as I mentioned, it's gone well enough that we want to accelerate that process and bring online an additional 30 episodes this year. All of the payers continue to be at the table with us. We are starting to get experience setting thresholds for performance for Medicaid 3 of the episodes that are currently in play. And we've started releasing performance reports on all of the episodes designed to date. In addition, the governor through executive order and then the Ohio Medicaid Department through rule has required that Medicaid providers, to be a Medicaid provider, are required to participate in the episode-based payment program. So significant progress in implementing the program to date. There are a few slides here that I won't cover in detail because the folks on the phone actually helped us to design this. Just a reminder that we use a retrospective model that pulls together all the claims related to an episode and then risk adjust that to create this picture, a comparable view across providers where you see providers meeting quality measures in the green on the right of this slide at very low cost. These providers are providing these services at those prices today. It's just that they're often not aware of it, and the value of that accrues to the insurance plans. The agreement here is that the payers share back some of those savings with those high-value specialists. And then where costs are high, indicated in the red on the left of this chart, an effort to bring that down and recover some of those outlier costs. Okay, this model then has now been applied to what we're calling Wave 1, which was initiated in 2015, and also Wave 2, which was initiated in 2016. You can see the list of episodes that have been launched in Wave 1 and Wave 2. And then really the subject of the new information today is you see indicated there a Wave 3 where a significant number of additional episodes are being prepared for design right now. And at the end of this call, one of the things we're going to ask of you is to identify colleagues who you believe would be most helpful to us in designing this next set of episodes. Okay, so with that as background, at this point, I think I'll turn the discussion over to Karin Hoyt to walk through some additional detail on Wave 1, Wave 2, and where we're headed with Wave 3.
Thanks, Director Moody. We'll pick up on slide 13, which will be a review of the threshold information for our Wave 1 episodes. So here we have the Wave 1, 3 episodes are linked to payment for the Medicaid program. The episodes, as you see here on the slide, are asthma acute exacerbation, COPD acute exacerbation, and perinatal. At this time, the other episodes listed here will remain reporting only due to low volume in the Medicaid program. We're aware that some of our commercial partners are reporting on both PCI and/or joint replacement and may choose to link those to payment. But for now, Medicaid, for those 3 episodes, providers will continue to receive an all Medicaid report with data aggregated across all of the managed care plans. So you'll still receive informational reports on these 3 despite the fact that they're not linked to payment. Here on the next slide, you see a snapshot of our episode of care provider report. Starting this year, episode reports follow the format that's laid out here. At the very top of the report, there's a set of eligibility requirements to help explain how volume, spend, and quality metric performance impact your eligibility for either positive or negative incentive payments. Additionally, for the 3 episodes for which Medicaid is launching in the performance period, again, those are asthma, acute exacerbation, COPD, and perinatal, you see the PAP curve, colored as it is here, with thresholds drawn over top the figure at the specific values. Those are in the middle of the front page of the report on the right-hand side. Note that for the reporting-only episodes, PCI and TJR, for Medicaid, no thresholds will be included and the PAP curve will be grayed out. On the Medicaid website, there's an updated How to Read Your Report document that walks through each individual chart on every page. Probably the biggest change from reports prior is that this report gives a quarterly view, meaning that every report will not include a full year's worth of data, except in the bottom right-hand chart on the front page. You see here that we show performance by quarter. The reports just released at the end of quarter 1 include 3 quarters of data. Reports that will go out now for quarter 2 will include 4 quarters worth of data. The reports subsequently released in August will include only 1 quarter of data. August marks that first report. That's the cycle where there will be data from the performance period in calendar year 2016. The reason there's only 1 quarter of data is based on the feedback we received through our processes to date, where folks thought it would be better to only see data on which you'll be evaluated versus a running full year of data that would include information from the prior calendar year. Additionally, you will receive a report if you have at least 1 valid episode during the reporting window. That's a change from how we've done this in the past, where you would only receive a report if you had 5 valid episodes in the full year's worth of data. In the next section, we'll have some additional pages to illustrate the concept. So moving on to the next slide, we have a reminder here that Medicaid has set thresholds for the quality metrics that are linked to gain sharing for the first wave of episodes. Quality metric thresholds were set such that 75% of providers passed based on historical performance. The quality metric thresholds will ramp up to the top quartile performance over the next 5 years. As a reminder, the state's initial goal was to set that quality metric threshold in the top quartile of current performance. However, to enable enough providers to participate in the program in a meaningful way, we had to set the threshold such that 75% of providers would pass metrics. So you see the resulting thresholds on this slide here for each of the first 3 episodes. On the next slide, we'll move to a reminder on our spend threshold methodology. For Medicaid, which includes all of the managed care plans as well as fee-for-service, there is a single acceptable and a single commendable threshold for each episode. The acceptable threshold was set such that 10% of providers would be above the acceptable threshold and would incur a negative incentive payment. The commendable threshold was set such that the program-wide view across fee-for-service and managed care would be budget neutral, assuming no change in behavior. This same methodology was used for all 3 of the Wave 1 episodes tied to payment. So it was used for asthma acute exacerbation, COPD, and perinatal. Historical data was used to inform the thresholds for these first 3 episodes. As such, we applied an inflationary adjustment based on inflationary factors identified by our state actuaries and used in the Medicaid managed care rate setting process. The inflationary adjustment takes into consideration both our fee schedule and policy changes. Slide 17 gets us to the end result of all of the mechanics surrounding this. So the threshold values shown here incorporate those inflationary adjustments I just mentioned, and they're based on risk-adjusted episode reimbursement versus what a provider is typically paid for specific services included in an episode. These thresholds are now included on reports for the 3 episodes you see here, which again are the ones linked to payment for the Medicaid program. There's additional content related to the thresholding and the calculation of the positive and negative incentive payments from our last webinar we hosted in December, which is posted online via the OHT website. And there are also additional pages posted on the Medicaid Payment Innovation website, which detail more specifics to each of the episodes under both Wave 1 and Wave 2. Moving on, we've had a number of questions on reporting recently, given the addition of new reports being released from the Medicaid program. So we wanted to share an overview of all reporting happening, including timelines and responses to some of the questions that have come up. This page describes what reports are being produced, from whom they are being released across all 13 episodes, both Waves 1 and Wave 2. You'll see here toward the top, for Wave 1, the 3 episodes linked to payment, ODM releases fee-for-service reports via the MITS portal, and the Medicaid managed care plans release their own reports, but all Medicaid reports should follow a similar look that we showed previously. So as part of our stakeholder work early on in the development, we aligned on the general report format and layout. For the episodes that are not linked to payment, again, both acute and non-acute PCI and TJR Wave 1, and appendectomy for Wave 2, providers should receive 1 report across all Medicaid, which is a view of performance across the integrated Medicaid data set. So that's both fee-for-service and all of the managed care plan claims. It's not shown on this page specifically, but I also want to note that commercial partners are releasing reports for a subset of the episodes that they've selected for Wave 1 as well. Now shifting to the lower part of this slide under Wave 2, the process is slightly different on the Medicaid side for all of the episodes except for appendectomy that I mentioned earlier. Based on feedback from many of you that it's challenging to have multiple reports coming from different sources, we decided to pursue a consolidated reporting approach. These reports are available in one single PDF file, which includes an all Medicaid payer view, as well as individual reports for each managed care plan. We have a picture of this on the next slide. And I would just note that to date, commercial plans have not yet released reports for Wave 2. We would see those coming in the future. So moving ahead to what our new consolidated report looks like, on this slide, you see a screenshot of an example colonoscopy report released in our last cycle for Wave 2. Note that the cover page lays out all plans for which a given PAP had at least 1 valid episode. This cover page allows you to click on a plan and go directly to the page in the PDF where the report begins. Reports were included in a single PDF versus, again, the separate documents on the MITS portal, based on feedback we received to date. Due to the fact that the MITS portal administrator is the person with access to pull down the reports, having everything in one document can streamline the process of someone accessing the reports and then sharing the PDF with the relevant set of providers within the practice. Currently, we're just in the process of releasing Wave 1 reports this week, and we'll be delivering Wave 2 reports before the end of the month. Also included on the page here are the dates included on each of the reports. So if you look at this screen directly below where it says colonoscopy, you see reporting period covering episodes that ended between January 1st, 2015 to September 30th, 2015. For Wave 1, we're still sharing what we call virtual performance reports because the data included, which is calendar year 15, is not into the performance period, which started 1/1/16. And just as a reminder, August marks that first quarter for the first time when reports will include data from calendar year 16 that ultimately count toward the calculation of positive and negative incentive payments. Whether or not a provider is eligible for an incentive payment will not be determined until the middle of calendar year 2017, when we're able to look back at the full year of episodes ending in calendar year 16. So due to claims lag and some other runoff issues, we're delayed in when we look at the calculation for that performance period. The next slide is a screenshot. We wanted to turn to some frequently asked questions that we've received. Here's a screenshot of the MITS portal where folks can access their reports. Reports from ODM are available here through the portal, and this is a screenshot of what a person who would log in would see. Note that it's typically an administrator in the practices that has access to this. Again, as we mentioned, being able to download the consolidated reports and then distribute to providers within the practice is an ease of use issue with the consolidated. Additionally, folks can download CSV files through the MITS portal. These are complementary to the PDF reports, and they include information on both valid and excluded episodes ending during the reporting cycle. We've grayed out sensitive information on the screenshot you see in front of you, but you can see that these files can be used as a tool to help you understand sort of the key sources of variation, if you will. For example, you could use this file to look at the breakdown of average risk-adjusted spend by rendering provider within the practice. You can also look at the impact of specific services. For example, you'll see columns that relate to inpatient or pharmacy spend. These CSV files also now contain quality metric performance information so that you can see how by episode quality factors into the spend. Both valid and excluded episodes are also included in the CSV file, so you can also see why specific episodes are excluded. A couple of additional questions that have come in more recently that we wanted to share responses more broadly. If you have questions on your report, please reach out to the specific payer associated with the report, whether that's Medicaid or one of the managed care plans or one of our commercial partners. For Medicaid, you'll see here the provider hotline is listed. Additionally, we're looking at including contact information for each plan in the cover letter of the Wave 2 reports moving forward. We've heard some feedback that it is a bit confusing in terms of who to contact in those consolidated reports because they have information from multiple sources. So we think there will be some value added in listing one specific contact per plan on those reports moving forward. We also have a question, will Wave 1 reports continue to come from different sources, and what will happen for Wave 3? So just to note, for the remainder of 2016, Wave 1 reports will continue to be generated by each plan and ODM for fee-for-service. For Wave 3, it's likely to follow a similar approach to the Wave 2 episodes. So that Wave 3 reports will likely have the consolidated approach. All right, we'll move on. Now that we've covered updates on Waves 1 and 2, we'll shift our attention toward our plans for episode design for Wave 3. Slide 25, you see included here is the proposed timeline for Wave 3 episode design. It looks slightly different from what you may have seen previously. As mentioned early on in the presentation, the goal is to accelerate design and have 30-plus episodes ready for reporting in calendar year 2017. A select subset of the episodes will undergo revised CAG 2.0 approach, for which we'll share additional details here. But basically, the plan is to go through a formal feedback process with a group of providers to get input on targeted solicitation materials, including related analyses. Episode design will follow a batched process with roughly 5 to 7 episodes being designed in one batch. The first few batches will wrap in 2016 and launch for reporting in Q1 of 2017. The remaining episodes being finalized in 2017 and launched for reporting in a future quarter. For Wave 3, given it's a shift from prior waves, we wanted to share a bit about the details and the thoughts behind our shift. Given all the progress on the episode side to date, we think we have a real opportunity to accelerate episode design and reporting in tandem with the launch of our Ohio PCMH. Operational changes like the consolidated reporting we covered today enables us to shift from a steady state of roughly 7 episodes a year to pulling design forward and reporting on more episodes in 2017. We know that doing this effectively means continuing to adhere to our guiding principles like leveraging decisions from prior waves, as well as other programs in flight, and transparently sharing all details of our design, but while also innovating the design approach, including the way we seek provider input. Our accelerated approach leverages the work done to date with all of you. It's designed to be responsive to provider feedback regarding cumbersome midday in-person meetings while continuing to get Ohio-specific input critical to the model. We think our accelerating the process will allow us to realize projected impact much earlier. Prior to going over the initial list of our Wave 3 episodes planned, we wanted to take just a couple of steps back and review the 6 archetypes we consider for episode design. I think most of us tend to associate episodes with planned procedures, but as many of you know by now, we've also already designed episodes related to acute emergent conditions like asthma exacerbation, also acute non-emergent conditions like URI. And as we look toward Wave 3, we'll be adding chronic conditions like ADHD as well. So these 6 archetypes encompass the conditions and indications we consider to be episodable, if you will. The archetypes also tend to be associated with specific paths or sources of value. For example, for chronic conditions that you would see in column F here, the path is often the provider the patient sees most frequently for related care. While on the other hand, for acute emergent or non-emergent conditions, like you see here in column C and D, it's the provider that's first seen for the care. So as we look across the planned episodes for Wave 3, as well as Waves 1 and 2 already in place, you'll see they span all 6 of these archetypes. You can see a plethora of episodes listed on the slide in front of you. And you can take a minute here to read through the list. While you do, I'll note, we've highlighted episodes that are next up for Wave 3. You'll see ADHD and ODD. Those will follow our more traditional CAG approach, with meetings of the CAG in person roughly 3 times in Columbus. You'll also see listed here HIV and neonatal, which are sort of first up out of the gate. They'll be our first Wave 3 episodes to follow our CAG 2.0 approach. In the next couple of slides here, we'll detail that refined process. Listed here are the key components of the CAG 2.0 approach. Ideally, each CAG will involve roughly 15 to 30 clinicians. Those are similar in size for the CAGs that you're used to. As has been the protocol in the past, we're seeking recommendations from a variety of sources, including yourselves, our payer partners, and other related clinical organizations. Recognizing some people will be new to the process, we'll encourage them to watch or attend our introductory webinar that explains the details of the episode model. For each episode, there'll be a brief concept paper. That paper will summarize the design as well as the key set of questions. This paper will be used to solicit input. It'll be developed for all episodes to act as an intermediate between the roughly 2-page definitions that we currently have on the ODM website for both Waves 1 and 2 and those detailed business requirement documents. In addition to the introductory webinar, once materials are delivered to the providers, there'll be a call for any clarifying questions. Clinicians will be given roughly 3 weeks to review the materials and provide feedback through a structured template. Following collection of feedback on an as-needed basis, there may be a targeted focus group or interview as necessary. Once the feedback has been reviewed, updates will be made to the definitions as appropriate. And then we'll release an updated concept paper that will be shared back with the CAG participants in roughly 4 to 6 weeks following the review period. That would be, of course, in advance of any materials being posted online. So what you'll see here is a timeline for the activities. Note that we'd like to have recommendations for the first 4 episodes. So this is our ask of you all today. For neonatal, HIV, ADHD, and ODD, we'd love for you to submit within the next week or so recommendations that you have for participants in the CAG. We'll use a survey tool for recommendations for that Wave 3, and that survey will be distributed following this call. For ADHD and ODD, the ask is for CAG participants to attend roughly 3 meetings in Columbus, as previously mentioned. There will participate, folks will provide feedback on design elements. And then for HIV and neonatal, the specific ask is of individuals to attend the introductory webinar, review the targeted materials we mentioned before, and provide feedback over that 2 to 3 week time frame. Things such as the codes that trigger episodes, what the included claims would be, what clinical exclusions there might be, and what your thoughts are around quality metrics. Again, just as a reminder, following this webinar, we'll distribute the survey link with details following. And as we wrap up, we thought it would be helpful to give you a screenshot of the Medicaid website currently that includes all of the detailed documents we just referred to. So this is the snapshot of our Payments Innovation website where we house all of the information. We greatly appreciate your continued commitment to our innovation efforts. We've made tremendous progress to date, and we're all very excited about what lies immediately ahead. We'll turn now to any questions folks have with our remaining time. If there's not enough time to answer all of them, we'll distribute questions and answers to participants following the webinar.
The first question that we received is in regards to performance reporting. We are only receiving performance reports from 6 Medicaid payers to date, ODM plus 5 Medicaid plans on Wave 1 episodes. Which of the other payers are issuing reports, and how do we contact them to ensure we receive those reports? How do we determine whether we should be receiving Wave 2 reports? When will more detailed claims information be made available to providers so that the data being used can finally be validated?
Great question. So I think there are a few of them embedded in there. First off, just to reiterate exactly what's in the beginning of the question, and that is for Medicaid fee-for-service and all of our managed care plans, the reports are being issued for the beginning of this performance period. For the commercial plans, they have not yet released those Wave 2 reports. We can certainly circle back with them as a part of our regularly scheduled touch base with our commercial plans to get some insights in terms of their timeframes and expected release of reports, and specifically tied to which episodes. I believe there was also a question embedded related to claims data. We know that right now we have reports that are tied to the CSV files that are distributed to all of the providers who are identified as PAPs. And we look toward including additional information in those CSV reports as soon as we possibly can. One of the pieces of feedback we've received from folks to date is that it's very difficult to tie specific episode information to individuals seen within a practice. And so we are working with our partners to figure out the best way to identify who the people are within an episode without disclosing too much information. So we look forward to sort of revamping those reports and including some of those elements that will help you get at the more detailed claims information.
At this point, I jump in too and say that early on we made a decision that we would approach this as a voluntary partnership with the commercial payers. We didn't want to go down the regulatory route, and I think that decision has allowed us to get more done in partnership. That said, however, we do have some interesting relationships through our state of Ohio employee plans with Anthem, Aetna, and Medical Mutual. I was just at a conference yesterday where OPERS, our public employee retirement system, is talking about their expectations of using these value models. So I think in addition to the commercial plans voluntarily using the episode model and particularly the primary care model, we will continue at the state level to use all the levers we have to encourage participation in the value-based models.
We'll go on to the next question. When will the ODM Payment Innovation website be updated with current documents? The code sheets don't list any ICD-10 codes. Also, the threshold documents don't list the quality metric thresholds, only the cost thresholds. Will this information be available to providers?
So the website should be updated. We just recently finished our conversion from ICD-9 to ICD-10. I believe some of the code sets are ready to be loaded if they have not yet been loaded. So those are impending very shortly. The second part of the question, on the thresholds. The quality metric thresholds are information that we can certainly add to the website, and we'll do so.
Next question. I know that the Ohio Plan for Improving Population Health is under development. Can you discuss how you envision your population health strategies and measures aligning with the support these clinically based episodes?
Yeah, that's a very timely question. Just last week, the legislature approved legislation that takes a significant step forward in population health planning for the state of Ohio. Currently, every local health district is required to conduct a health assessment and put together a community health improvement plan. And every hospital, as a condition of maintaining tax-free status, has to do an assessment and put together a plan. So we have some 300 assessments and plans around the state at any point in time, not necessarily coordinated, at different levels of geography and conducted on different time frames. So what the new law does is simply say that beginning in 2020, every health district and hospital will move to the same 3-year planning timeline. So hopefully those assessments can be conducted as one and not separately. That way we'll be able to more clearly identify population health priorities at the community level. That then will give us the information we need to connect primary care performance measures to be more responsive to those community level population health needs. So there are several very large systems involved as we think about migrating our current process and infrastructure to a better form of collaboration. But I do think the bill enacted last week is a significant step in that direction.
Is there any insight on the metrics that are being discussed with Wave 3?
The Wave 3 information is just sort of starting to churn at this point, and I think what we are looking for right now, just as a reminder, are the folks who would be participating on the in the CAG process with us. We don't have any particular insights to share on this webinar to date, but we are ready to get moving on the CAG process as soon as possible.
And the starting point whenever we begin a new episode is to look around at design work that has occurred already and not start from scratch, but to take the best evidence of what seems to be working as an episode already, and then basically posing the question to our Ohio clinical experts, does that model work for us, or do we need to make changes? So we'll follow that same approach this time as well.
Since we only have 3 minutes left, we'll take this one last question, and then any additional questions we will follow up after the fact on. So last question, is there a plan to ultimately make this information available to consumers or patients?
Yes. Our vision is of complete price and quality transparency at a point in the future. However, these models are extremely complex. They include very sensitive information. So we are being very mindful of learning about the power of the information we hold and getting that in the hands of the specialists who can make immediate use of the information. That is our priority with the episode work. As the models seem to be stable and generating a comparison of performance that folks view as legitimate, then we would ask the question about what of that should be made more publicly available. For example, our next step, I think, would be to make that information available to primary care. So at the primary care level, as folks are needing to make referrals to specialists who can simply provide value, the information that's available in the episode reports available to primary care to make those decisions makes sense as a next step. So we're not going to rush into things, but I do think what we're learning is an indication that this information is powerful, and ideally at a point in the future will help consumers make decisions about their own care. Okay, with that, thank you for the time. This is tremendous work. We appreciate that it's complex. We're trying to strike a balance between enough detail to make sure the models are fair to the specialists who operate within them, but at the same time being straightforward enough that we're able to align the payers around a common view that at the end of the day sends a clearer signal about what we're willing to pay for and willing to pay more for. So thank you for engaging us in this work. Please do look for the survey that we send around, and I look forward to working with some of you in the weeks to come as we design the next round of episodes. Thank you all.